We'll get started in just about 1 minute. Okay, well, welcome back, everybody. Hope you are well nourished and you are ready for more food for the brain this afternoon. So one of the critical partners for CMS is our sister agency, the Health Resources and Services Administration. HRSA, as you know, works to fill the healthcare gaps for people who live outside the economic and medical mainstream. HRSA helps expand access to quality healthcare through an array of grants to state and local governments, healthcare providers, and health profession training programs. And one of HRSA's offices, the Federal Office of Rural Health Policy, advises the Secretary on healthcare issues relating to rural communities. They are number one on my speed dial. It is my great pleasure now to introduce to you Jim McCrae, who became acting administrator of HRSA in April of 2015. Previously, as head of HRSA's Bureau of Primary Health Care, Jim managed the $5 million budget that supports the health care safety net for many underserved people around the country. Most of these funds come to the 9,000 health center sites. From 2000 to 2006, Jim served as associate administrator for HRSA's Office of Performance Review, and he joined HRSA in 1992. We are absolutely delighted to have Jim McCrae with us today. Please join me in welcoming Jim.
Well, hi, everybody. It's great to be here. I know we're on the video also, so good morning to those that are still out on the West Coast, and for those who have come back from lunch, thank you for being here. I think this session in particular is extremely timely in terms of focusing on rural issues. It's something that I know we've been working very closely in partnership with CMS about. It's definitely something that's a focus for our agency, the Health Resources and Services Administration. So first and foremost, I just want to thank John and Kara for organizing this session, but more importantly for really spearheading this Rural Council. I think this is absolutely essential in terms of the work that we do together in partnership. I know you heard earlier from Andy Slavitt and from Karen DeSalvo. They also are true champions in terms of rural health, and in particular, really always focusing on what we can do more of, in particular in the next 90 or so days in this administration, but even more importantly going forward in terms of our work together. So I just really want to commend them for creating this Rural Council and for having this particular session. As John mentioned, we do work very collaboratively together. In fact, this partnership has been going on for a number of different years in terms of this partnership between HRSA and CMS. I actually started my federal career many years ago on the CMS side. And so really got a deep appreciation for the challenges as well as the opportunities about dealing on the payment side. The folks here do not have an easy job in terms of navigating all the different constituencies, trying to make sure that you're paying for value and not volume, and how do you do it in ways that reflect what's going on in the nation, and I think even more importantly now, what's going on in rural communities, and how do you develop a payment system that truly reflects that and is responsive to that. We at the Health Resources and Services Administration sort of play the other side, which is to really support the service delivery programs that we work with throughout a variety of different programs, whether it's our community health center programs, our maternal and child health programs, our Ryan White programs that provide services to people living with HIV, and of course our rural health programs that deal with outreach and enrollment and work with hospitals and a variety of different providers. We also, of course, work on provider issues from the workforce side. And so our partnership has been very strong in terms of working with each other, really sharing what the challenges are and what the opportunities are. But I think most importantly for both of us it's hearing from you about what the real issues and challenges are on the ground. Because we can have the best policies and even the best programs, but if we're not responsive and reflective to what it is that you all are actually experiencing and really need us to be thinking about or trying to change, we're not going to be successful. So that's why I think meetings like this are critically important, and I hope this is just the beginning of really a blueprint for us going forward. I know after this session we're going to break out into different work groups to really identify some key issues for us, and in particular I would just ask you to give us some feedback and advice about how we can move forward in terms of our programs and policies, what things are actually helping you with some of the real challenges, which I'll get into in a minute, but also what are some of those things that are standing in the way in terms of you being successful in your rural community. So again, just thank you all for being here, and a big thanks to CMS. So rural issues are, of course, key in terms of what we do in the Health Resources and Services Administration. We work on a number of different programs that are providing care in rural communities, and I'll go through that in a minute. And I think Andy touched on this, what we see out there is that about 15% of the population, or about 46 million people, live in rural communities. But yet when you look at the healthcare landscape, which is something that we focus on a great deal, you realize that only about 9% of the physicians in this country are in rural communities. And if you look at HPSAs, which we're responsible for developing, more than half of those HPSAs are actually in rural and frontier areas. And so we are very much aware of the concerns in rural communities. In addition, as John mentioned, and we're very proud to have them be a part of our agency, is the Federal Office of Rural Health Policy. They are a key instrument, not just within HRSA, but across the department in terms of raising issues of concern to rural populations and rural communities. In fact, and sometimes it's complicated, and we're even thinking about how to explain this when the new group comes in, they really play two distinctive roles, and two critical roles in terms of our work. The first role is to provide policy input and research on rural issues that impact the entire department. So they are advisory not just to HRSA, but they're actually advisory to the HHS Secretary. And I think, as Andy and others mentioned, the HHS Secretary, Secretary Burwell, as well as Deputy Secretary Mary Wakefield, have a keen interest in rural. And so Tom and his entire team have been kept incredibly busy, wouldn't you say, Tom, in terms of just making sure that as we're developing programs and policies that we are thinking about what the impacts are on rural. And so one of the things that they're able to do is to look at policies that impact not just in HRSA, but also CMS policies and others, to really look at whether they're making an impact in rural, either positively or negatively. And as I've said to Tom and the team, they really are the conscience in a lot of ways for what we're doing to make sure that we're not forgetting about and that we're always putting front and center rural communities. At the same time, within our agency, they oversee a number of different grant programs, programs that do everything from rural health outreach to working with hospitals, research centers, just a variety of different activities. And I think what really makes them in a unique position is that they have the opportunity to both do policy work at sort of a very high level, but then also, like I mentioned earlier, work with programs on the ground. In fact, we actually had a meeting just this morning with the Rural Network Development Program, and it was a great session. Paul Moore was there with me, as well as several others, to hear what they were able to do with our grant, but more importantly, what were some of the challenges that they were experiencing and what we could do both from a program standpoint and from a policy standpoint. And no surprises, they raised issues which we're actually going to talk about this afternoon. So they talked about HIT and some of the challenges around interoperability. They talked about just some of the issues related to workforce and the challenges both on the provider side, but one of the things that they really asked us to focus more attention on is really the CEO, the leadership side of rural health. So what can we do to grow that next generation of rural leaders? Because they mentioned that the turnover is, in these CEO positions and other things is about every 24 months, which you cannot gain real stability and change if you're constantly changing in terms of the leadership, but yet we're constantly seem to be recruiting. And so they gave us feedback about what we could do programmatically to support greater leadership. And that's really important, I think, for both us and CMS, is to get your feedback in terms of the work that we do. So let me just jump into a couple of issues that I know are probably first and foremost on your mind, and just share a little bit about what we're doing in HRSA to help address that. One is workforce. If there's one issue since I've become acting administrator that I hear more about and hear about every day, it's about workforce. It's how can we do more to get more people interested, whether it's in primary care, but in particular, how do we get more providers to be interested going into underserved communities, rural communities, frontier communities? What can we do to better support them? And then once we have them there, how can we develop programs that actually support them staying in those communities for the long term? And so we have a number of different programs that we support through our agency that support programs across the country, but in particular, we've been making a lot of changes to make sure that they focus on rural. And one of the key pieces that we've seen, and I would just be very interested in your feedback, is that exposure matters, so that when people are thinking about either going into a medical school or a health profession school, if they've had exposure to rural and frontier, underserved populations, that makes a difference about whether they'll end up practicing there. Once they're in health profession schools, if they actually have the opportunity to go out and train and work in a rural or underserved community, it makes a difference. But yet it's so challenging for us to be able to find sites in those rural and underserved communities to be able to give people that exposure. And so one of the things that we're looking at is how can we create more opportunities in terms of the training. And then once they are done with their training, can we create incentives to help people go out and actually practice in rural and underserved communities? And so one of the things that we did just a couple of years ago in 2012 is we actually expanded the National Service Corps to include critical access hospitals as one of the different sites where National Service Corps people could provide services. And we're very happy, although we want it to grow even further. We have about 225 critical access hospitals that are now approved National Health Service Corps sites, and we have about 51 National Health Service Corps providers providing care in those facilities. But we're very interested in getting more critical access hospitals engaged in this program because we think it's a great opportunity, again, for people to be placed in rural communities. We also, under Tom's leadership, have done a lot with CMS around the rural training track, where we're supporting family medicine residencies. And we've actually doubled the number of programs to almost 42 now since 2011. And these have been tremendous in terms of, again, giving people exposure, but more importantly, helping people stay in rural communities. We also have done a lot of work, I'm sure you've heard about the Teaching Health Center Graduate Medical Education Program, which is very much focused on supporting training in primary care settings. So getting training outside of the hospitals really into the primary care settings. And about 50% of our health center grantees are focused specifically on rural communities. And again, by doing all of this, we hope that it will increase just the volume and the availability of those providers. Overall, through all of our different programs, we're providing support to about 180,000 students that are serving in rural communities, and we're providing about 11,000 training sites in rural communities, but that's still not enough in terms of making an impact. And of course, last but not least, which I know many of you all utilize, 3RNet, we support through a variety of our different programs. So the National Rural Recruitment and Retention Network actually helped support the placement of over 2,000 clinicians in 2015. And so we see workforce as a key issue, and we'd be, again, very interested in ideas that you all have in terms of how we can take some current programs, but also maybe identify some new areas for us in terms of that. In terms of service delivery, some of our main programs are the Community Health Center program, which plays a critical role in terms of providing care to almost 24 million people across this country. About 47% of those sites are either serving or are located in a rural community. And what we've been working on over the last several years is to expand what it is that these health centers do. So it's not just providing basic primary health care services, but it's also expanding into oral health, which we know is a huge issue, especially in rural communities. They are expanding in terms of behavioral health, both the mental health side, as well as more recently in substance abuse, because again, we know the impact in rural communities. And in particular, to also expand their capacity around what we call enabling services. So whether it's case management, patient education, or even transportation, those are some of the areas that we're trying to focus on in terms of expanding the reach of these health centers. We also have been working to expand our presence in terms of our Ryan White programs, because again, where you see the epidemic around HIV occurring much more frequently is now in rural communities. And the program, as I think many of you know, originally began mostly in the cities, and now we're recognizing the need to shift some resources and some efforts from some of those cities where the epidemic and the disease is more under control to areas where we need to focus more time and energy. And so we've been undertaking a number of different steps to look to see how we can drive to where it is that we need to go. We also support the federal home visiting program, which I know many of you have become aware of just in the last several years. This is a program, it's sort of like going back to the future as I describe it, but the idea to go back into people's homes to actually provide health care, in particular for pregnant women and their families, and do it with an evidence-based orientation. So providing services within the home, using evidence-based practices to make an impact. And in particular, because this is a program that's now in all 50 states, there are more than 400 rural counties that are working with us around that whole effort. So that's absolutely essential. So in our programs, we're always thinking about what we can do to improve them, but also in particular what we can do to impact in rural communities. I couldn't stop with service delivery if I didn't talk about outreach and enrollment. I know you probably already gotten quite a bit of information about that, but just in case you don't know, open enrollment begins when? November 1st, yes, all right. And the Secretary this morning set a goal for us to increase from last year by 1 million more people to be enrolled, which is an ambitious goal, but I think a goal that is achievable. But it will definitely take work on everybody's behalf to get there. And so to the extent that when you go back, you can help us with enrollment, especially again in rural communities, which we know are actually benefiting more, even though some of the stories don't always say that, in some cases even more than urban communities. Just by being able to have health insurance has made a tremendous impact. So again, it's also important for us to hear what some of the challenges are related to that. So again, we can work together. Another key area, which I know is one of your breakout sessions later this afternoon, is around telehealth. This is something that we see as absolutely essential in terms of healthcare and healthcare services, because in particular in rural, but especially in frontier communities, telehealth may be the only way to be able to get services into these communities for the patients that you're seeing. And so we have developed a really robust telehealth program in our Federal Office of Rural Health Policy. In particular, I think it's now 7 telehealth TA centers that are available to help with the different work that goes on. How many is it, Tom? 6 or 7? All right, 8 maybe, I don't know, we'll find out. But we have a number of different telehealth centers, TA centers that are there to help. But in particular, the idea is to help rural communities make the business case about why it makes sense to do it. We know there are issues with respect to reimbursement. We've been engaging with CMS around a lot of those different activities to see what we can do together moving forward. But we know in the end, by being able to have access where people need it, it's absolutely essential in terms of our work. And so we look forward to working with you through some of the challenges as well as some of the opportunities I think that telehealth presents in terms of sharing information, getting access to people. That makes a big difference. Just a couple of other things I want to touch on because I know you all are experiencing it and we are looking at it from where we sit. We know that there have been a number of different rural hospital closures over the last several years. In fact, I think since January 1st, 2010, there have been a total of 78 rural hospital closures. 51 have been prospective payment system hospitals, and 27 have been critical access hospitals. And we know there are a variety of different reasons why these hospitals have had to close. In some cases, it's just literally the economics of the situation in terms of low patient volume, declining inpatient utilization, demographic changes in terms of the communities themselves, as well as changes in the payer mix that in some cases have just pushed people over the edge in terms of what they can do. But even so, we know there is real strength in rural communities and in rural hospitals. In fact, when you look at some of the data, patient experience is actually much higher in rural hospitals than it is in urban hospitals. And so we think and believe there are some opportunities for us working collectively together to figure out what can we do to work to support hospitals that are currently there, how do we do it in ways that make the most sense for the rural community? So in some cases, it may mean just providing more support around how do we do better around operations, transitioning to the new environment. In other cases, because of just literally changes in demographics, it may mean looking at different models of how to provide services in that community. Maybe it's not a full-fledged hospital in the traditional sense. Maybe it's a new model. And we've been working with a number of different folks about what some of those new models might look like. Or it could even transition to more of a primary care model with connections with telehealth, with transportation and other things. So I think there's some definitely opportunities for us in terms of that work. In fact, just recently we awarded about $2.5 million to a series of rural health network planning grants that were focused on communities that had either lost their hospital or were in danger of it, to help them plan beforehand. Because the worst time to do a lot of this thinking and strategic work is when you're in the middle of a crisis. It's much more important to do it now. And so we are definitely interested, again, in your feedback about how we can better support communities that are working on that. In particular, we've also been working with the Medicare Payment Advisory Commission, the National Advisory Committee on Rural Health and Human Services, as well as CMMI, the Innovation Center here at CMS, to look at how we can support different models in rural communities that, again, may not work in the sort of traditional hospital sense, just given some of the changes in demographics and other things. But there are definitely some opportunities. In addition, we have been looking at all of our different programs to see how we can provide better support through those programs to help with just some of the operational and just some of the challenges of the new healthcare environment. And one of the new things that we've done is we've actually created a toolkit and a resource compendium to help assist state offices of rural health that are actually working with vulnerable hospitals and communities. Basically a toolkit that helps go through the different stages that you need to look at in terms of when you're making decisions about really what makes sense going forward. The last two things I want to talk about, and then I do want to open up for some questions for Tom to answer. No, I'm kidding. Is delivery system reform. So you've heard a lot of talk about that, and it all sounds good, but actually making it happen is not easy. We're looking at different changes in payments. We're looking at changes in terms of models of care delivery. We're looking at, a true revolution in terms of technology and the use of information. Those are not easy, and those are really not easy in communities and in providers that have already been stressed. And so one of the things that we've been talking about, in particular with John and others, is how do we better support rural providers and communities in terms of making some of these transitions. And this is absolutely essential because the realities on the ground in rural communities are very different than they are in urban. And so looking at the realities of when you're looking at measuring quality in a low volume provider, you can't look at it the same way as you can in a high volume urban setting. It just doesn't work. In fact, one of the things that we've talked about is that for some of the services that are even provided, you have to have a certain level of volume just to hit the quality measures. And so holding people to standards that they're just not going to meet because of the volume doesn't make any sense. And so how do we move forward, though, to be able to capture what the impact is and what are true reflective measures of quality in rural? And so we are, again, very interested in your feedback in terms of as we move forward with all of these different things in terms of standards. In particular, there have been a couple of things that we've been doing that we've started, and a couple of things that we're just recently going to be announcing, or actually have been announced. I'm sort of looking at Tom to help me with this part. But through the Medicare Beneficiary Quality Improvement Project, the Federal Office of Rural Health and CMS have partnered to encourage critical access hospitals to report on key national quality metrics and engage in quality improvement activities. And this was an effort that really took us working together with CMS, and I really want to applaud them for working with us and with you to look at how we can better support rural providers in terms of reporting. So what can we do to make it easier? How can we make sure that we align the different performance measures and eliminate duplication of efforts? And what's really exciting about this is now we've been able, through our joint efforts in TA and other things, actually we now have 98% of our critical access hospitals that are participating in this quality improvement project, which I think is really tremendous and has helped them in particular and helped us be able to make the case that rural can report and actually does demonstrate significant quality improvements, and in fact, in a lot of cases, better than their urban counterparts. We also, as you all are well aware, have been actively engaged in all of the activities around the quality payment program. I know Andy talked a little bit about that this morning, all of the work around MIPS. And in particular, they were very supportive in terms of a lot of the feedback that many of you I know in this room gave. Hopefully you saw a lot of your feedback reflected in the final rules that came out. But one of the things that we're very excited about is we're actually going to be working with CMS on creating another voluntary system for rural health clinics and for FQHCs, federally qualified health centers, to be able to voluntarily report the quality measures under MIPS. To help them also get in alignment with those quality measures. And that's recognizing that the current payment systems need to be the way they are, but how do we position rural providers for the future? Because one of the concerns that I know I have and have shared with the different grantees and organizations that we work with is that we totally understand the value of prospective payment. We understand the value for the safety net in terms of a lot of the different payment arrangements that have been established. But we do worry that as the rest of the world moves forward in terms of moving from visits to volume, volume to quality, if we don't make some adaptations in terms of how we look at what we do, we maybe get left behind in terms of our rural and underserved and safety net providers. So how do we make the transition in a way that makes sense, that reflects the realities on the ground, but helps move us in this realm where we're not just paying for visits? How do we do it in ways that make the most sense? But how do we do it in a way that it doesn't undercut really the incredible safety net that we've all worked to establish and you all have helped to make sure that exists. So we are, again, looking for your advice and counsel in terms of how best to do that. And in particular, we're hopeful that as we collect this information under MIPS, we'll be able to see where providers, low volume providers, rural providers, safety net providers are performing well, and maybe where there's some opportunities for us to look at different measures in terms of our work. So we're really excited about everything that has been going on in rural. I think there are some incredible opportunities for us collectively to make an impact, whether that's in the area of telehealth. We'll be very interested in your feedback, whether that's in the whole area of quality, payment reform in terms of what makes sense, again, in a rural context, and then ultimately helping us determine what are those key policies that are either helping you move forward, or what are those key policies that are holding you back and your communities back. So I'm going to stop here and open it up for any questions that you all may have, but again, thank John and everybody for the opportunity to be here, but more importantly, the opportunity to truly focus on rural together, both from a payment side, from a financing side, and then from a service delivery side. So thank you all. All right.
Thanks, Jim. My name is Mario Gutierrez. I'm the director of the Center for Connected Health Policy. We're actually funded by Tom Shop to be one of those, actually 14 telehealth resource centers around the country. We're the,
14, great.
Yeah, we're the National Telehealth Policy Resource Center. And just picking up on your last comment, because as we work around the country with our sister resource centers and working with the safety net, one of the most challenging aspects of that is the way the reimbursement systems are set up for FQHCs. And all the incentives are there against using telehealth, where they're in the most opportune position to work with their communities to create virtual visits, to create remote monitoring in the home and such. What is your thinking and where are you going in terms of transition, as you were talking about before, in terms of clinical transition systems and reimbursement to help move this last frontier of telehealth of the safety net providers into that world? Thank you.
Sure. No, it's a great question. So a couple of things that we're looking at are things that we're doing internally that may be discouraging it. So one of the things that many of you have told us loud and clear, and I'm knocking on wood, I think we're going to be making changes in the next year around, is the whole issue of how do you count visits? Because right now we count visits only if it's face-to-face, but physically face-to-face. And so it actually creates a disincentive, because a lot of what we base a lot of our funding decisions are is the number of patients, the number of visits that are supported. We're trying to move away from visits just in general, but the fact that you can't count those patients is an issue. We also have been talking about FTCA coverage, which is another big issue in particular for us around supporting telehealth. And so we've been working with our lawyers to try to get us to move in a direction where we can actually cover things that are not in the traditional four walls. The other part, and we're working with CMS around this, is the whole issue of reimbursement in terms of just what makes sense both on the Medicare side and then again on the Medicaid side. And part of it is the challenge that we have with PPS with health centers in terms of having that be included, not included, how do we move in a direction that helps us all get there without undercutting the safety net, but we, of course, will be interested in any feedback that you would give us on that.
I'm Grace Zazak, and what I wanted to talk about was flexibility. We heard that in the session right before lunch, and you talked about the loan repayment program, you talked about, and their scholarship programs.
Yep.
Some of the rural communities, particularly in the very outlying areas like the territories, need some flexibility. While those programs rightfully focus on physicians, nurses, that kind of education, what could really benefit these remote areas is flexibility where loan repayment and scholarship money may be available for something like medical coders and phlebotomists, because the training is less, the cost is less, and yet they can contribute to both the healthcare and the economic viability of the healthcare facility, particularly a hospital and then the community.
Sure. No, it's a good point. To be honest, it's one of the challenges that we have is that we're currently only meeting, I think it's 44% of the need that actually comes in through the National Service Corps just for the disciplines we currently support. And so if you add more and it doesn't increase, then it potentially takes away. But totally hear you in terms of the concerns, especially, in the territories. I've heard that quite a bit. We're actually looking at different creative things that we could do in Puerto Rico with Zika. We actually were able to get some resources as part of the supplement. And one of the pieces of that was a National Service Corps pilot. And so we're going to try some different things there to see if we can make it work in the context of Zika, but may have ramifications for what we do going forward. But definitely appreciate the feedback and the comment, because we definitely have heard that.
Thank you.
Thank you. Okay, last question. I know I run a little long. Last question.
My name is Gail Osgood. We have a place down in Summers County, West Virginia, which has which about 6 miles away, which is approximately a half an hour, 45 minutes by car. I can't exactly explain that. We have Summers County, which is a critical access. We have Summers County Hospital in Hinton, West Virginia, which is a critical access hospital. Sure. And which obviously you know.
Yes.
And but in Brooks, we don't. You have to literally drive 45 minutes away to get there. And the people around where we live are fairly, how do you say it, poor. Their average income is about $22,000
Sure.
a year, more or less, if they're lucky. And what do you do? And I run a little IT company.
Mm-hmm.
And we develop software to try to help them. And what we're doing now is we've resorted to putting little, to helping them, giving them tablets and helping them learn to use those tablets to try to contact their coordinators so that they don't fall off the map, which is the most common thing I hear from patients. Because I'm an IT person, I'm a geekette, okay? And the most common thing we hear is that I've fallen off the map. Things were fine while I was getting my physical therapy, my this, my that, and then I fell off the map. And so we try to help those people by giving them a tablet and teaching them how to use that tablet and coordinating and following up and giving them a call once in a while and saying, how are you doing with your tablet? And do you need any help relearning how to use it or remembering how to use
Sure.
it, et cetera? But we can't keep doing that because it costs a lot of money to do that.
Sure.
In the meantime, developing the software to help them, or to help the physicians, on the other hand, automate their records, and they have like rooms. You wouldn't believe this, but they actually have like rooms full of paper records, which are incomplete because they just don't have the time.
Sure.
Every single patient that they get is a future requirement for hours and hours and hours of time that they're committed to automatically. If they see one patient for an hour, that means that they've committed X number of their physician time to this patient for the next God knows how many years. And they don't have the time to automate those. So we're developing this stuff, and in the meantime, you guys up here are, as I see it, adding more and more and more and more regulations and changing the regulations to refine it, which is what your job is. But as we see it, you've built a house, and there are load-bearing walls in those houses that you're constantly changing.
Sure.
But it creates an even more of a problem in our trying to come up with a standard software that we can all use to make this problem affordable for not just for the patient, for the doctor, for the nurses, for the hospitals, for everybody to use. And I'm just an IT guy. Girl, lady, whatever. I'm a geekette, as I said. So what are you guys doing to reduce and standardize those things so that the walls in the house that you're building are a little bit more stable so that we can navigate those problems and make it a little bit easier for us to navigate so that we can actually build some software that, aside from the poor cots and gots that are on the market, which are, as I said, poor. They're poor. If you buy one, you have to adapt it, and it's very expensive.
No, and I'll do the 30-second. It's a longer answer, but I think, and we've talked a lot about this internally, and I would be interested. I think there's a lot of opportunity for innovation in the whole technology space in terms of healthcare. I think it is ripe for innovation in terms of everything from telemonitoring to telehealth to how you share information about patients back and forth. There are different issues that you've got to work through in terms of privacy, technology, requirements. I think those are some of the challenges, but it's helpful again for us to hear the feedback because there is sometimes the tendency to just add on as opposed to subtract. And I think there's an opportunity for us to hear, now that we've gotten about 5 years in terms of a lot of the meaningful use and other things, I think there is a ripe opportunity. And again, we've been talking to our colleagues both in ONC, the Office of the National Coordinator, as well as CMS to look at what makes the most sense going forward that moves us forward in terms of what is it that we need to do in terms of information sharing, but at the same time not keep adding different burdens or changing them. One of the things that we're trying to do, which we know is a big issue, and then I will stop, is just the number of performance measures that exist out there and all the different reporting requirements. And so we are trying to harmonize just those in terms of what you see. And we hopefully made some steps forward in terms of the MIPS, but clearly there's more that we need to do, and your feedback is really helpful for us. So thank you. And thank you very much for the opportunity for being here today, and good luck with the sessions.
Okay, so thank you. And that last question is actually a great transition into where we are going now, because it is your turn to roll up your sleeves and to help us figure out what are some of those issues that are affecting you locally in your communities and in your organizations, and how we can move forward. So these are our 3 breakout sessions that we have. You each in registering signed up for one. We are going to divide up this room here. We're going to take a 5-second while you guys get yourselves situated to close the wall off. So the first session, the Essential Health Services in Rural Communities, will be right here in this part of the auditorium. The second session, Enhancing Innovation, is going to go to the back side of the auditorium. And the third session in Modernizing Telemedicine is going to go down to the cafeteria. And for those of you who may not have gone there for lunch, we have some people to help guide you down there. We have discussion guides. We're going to be having a very interactive session, so we're hoping you all are caffeinated and have your blood sugar up. For those of you who are in the regions, you all have a topic that you're going to be discussing based in part on sort of how you signed up, and we will be incorporating that feedback back into it. And for those of you who are joining us virtually, we still want your feedback as well. We can't quite facilitate a one-on-one conversation with all 400 of you, but for each of these topics, we welcome you to provide us with your comments, thinking about what are, for example, the essential health services that you think are important, and to share that feedback with us. So you can email us at omh@cms.hhs.gov. Again, that's omh.cms.hhs.gov. We're not going to respond to the feedback you provide right now, but we are going to triage that and feed that into the conference summary that we will be developing as we come out of this. So again, breakout session number 1 right here, breakout session number 2 in the back. Innovation and telemedicine, is down in the cafeteria, and we will be back to report out at around 2:45, 3 o'clock. Thank you.